Here is our case. A 24-year-old Filipino nurse is 14 weeks pregnant by date. She complains of vaginal bleeding as well as severe nausea and vomiting. Her uterus extends to her umbilicus, but no fetal heart tones can be heard. Her blood pressure is 150/95. A dipstick urine shows 2+ protein. So, why do I mention Filipino nurse? Because gestational trophoblastic neoplasia or molar pregnancy is 10 times more common in the Philippines and in Taiwan. Epidemiologically, that's just the way it is. She is 14 weeks by dates, but the uterus is at her belly button, at her umbilicus. What is the gestational age of a pregnancy that is at the umbilicus? It should be 20 weeks. So we have a uterus larger than date. She complains of vaginal bleeding. Whenever you have early pregnancy bleeding, you've got to think, as well as threatened abortion, inevitable abortion, incomplete, and all those things, you've got to think of molar pregnancy. The most common symptom of molar pregnancy is early pregnancy bleeding. Severe nausea and vomiting. The degree of nausea and vomiting appears to be related to the level of beta-HCG. With molar pregnancies, you can have exceedingly high levels of beta-HCG, which is associated with very high symptoms of nausea and vomiting. This can be truly hyperemesis. No fetal heart tones can be heard, even though the uterus is at the umbilicus. Why is there no fetus? This would be if it would be a complete molar pregnancy, where there is no fetus. She is 14 weeks by dates and yet has a blood pressure which meets the criteria for hypertension, which is 140/90. Her blood pressure is 150/95. And secondly, there is 2+ proteinuria on a urine dipstick. And we generally say that preeclampsia does not develop until after 20 weeks. Molar pregnancy is an exception for that. That would be important to remember for the exam. Preeclampsia can be found in a molar pregnancy before 20 weeks. All right, definition. Gestational trophoblastic neoplasia, which can be either benign or malignant, or another term we often use is molar pregnancy, is an abnormal proliferation of placental tissue involving both the cytotrophoblast and or the syncytial trophoblast. So it arises with pregnancy. It can be benign or malignant, and we'll talk about the different kinds. The malignant GTN can be characterized as either localized to the uterus or metastatic, and it can be classified into either good prognosis or poor prognosis. Now, if you've ever heard of a good tumor, this would be it. Good prognosis tumors, some of these are 100% curable. Let's look at the classification. We have benign and we have malignant. The benign gestational trophoblastic neoplasia is the classic hydatidiform mole. The incidence in the U.S. is about 1 per 1,000, 1 in 1,200. In the Far East, in the Philippines, in Taiwan, 1 in 120. So it is 10 times more common in the Far East. The benign GTN can be described as a complete mole, as an incomplete mole. The complete mole is the most common benign GTN. We talked about this previously in obstetrics. It results from fertilization of an empty egg with a single sperm, which then divides. The pronucleus divides. So we have a paternally derived or androgenetic normal karyotype. Now suppose you could have 2 X sperm, but the important thing to remember for the board exam is this is paternally derived. It is androgenetic and it is a normal karyotype, 46XX. There is no fetus, there is no umbilical cord, there is no placenta as we usually think of it, no amniotic fluid. All there is a uterus filled with grape-like vesicles composed of edematous avascular villi. It's important to realize these are avascular villi. Now these can progress on to become malignant about 20% of the time. That is the complete mole. No fetus, normal karyotype. The incomplete mole is the less common benign GTN. It results from fertilization of a normal egg with 2 sperm, so dispermic fertilization, resulting in a triploid 69XXY karyotype is the most common. So there is both from the mom and the dad, the chromosome. A fetus, umbilical cord, amniotic fluid is seen, but this is either going to be severe IUGR, severe symmetric IUGR, resulting 100% in fetal death. The progression to malignancy is less than with a complete mole, 10%, but it is not zero. So both of these, the complete mole and the incomplete mole, need to be followed up. And we'll talk about that in just a minute here. So that's the benign gestational trophoblastic neoplasia, the complete mole and the incomplete mole. Gestational trophoblastic neoplasia is an abnormal proliferation of placental tissue involving both cytotrophoblast and syncytiotrophoblastic. And you can see in this illustration here, on the top we have the endometrium, on the bottom we have the trophoblast, which is invading into the endometrium. You can see on the left there is syncytiotrophoblast, which is the outer layer. The inner layer is the cytotrophoblast. And this is what the gestational trophoblastic neoplasia arises from. It is a placental tumor. This is a CT scan of a molar pregnancy. The patient's head is to the right of the picture. The pelvis is to the left. And you can see in the just a little bit to the left of the midline is the large uterus. And it is homogeneous. As you can see, it's almost completely homogeneous, filled with the villi, the avascular villi. The complete mole comes from an empty egg, paternal X's only, diandrogenic. It is from the dad. It is 46XX, the most common chromosomes. There is no fetus. 20% go on to become malignant. So if it is benign, complete or incomplete, after 12 months of negative beta-HCG, we feel probably it's not going to come back, and so we would say it's okay to get pregnant. But if she comes back within that first year and the beta-HCG is rising, you don't want to start giving chemotherapy for a normal pregnancy. So what I would do if you were presented with a case like that on the exam is I would want to get a vaginal ultrasound to see is there an intrauterine normal appearing gestational sac, because it could be a normal pregnancy. Incomplete mole arises from a normal egg with dispermic fertilization. So we have 3 pronuclei, both maternal and paternal. 69XXY triploidy is the most common karyotype. The fetus is not going to survive. It is non-viable. 10% will go on to become malignant. So we need to follow up. No chemotherapy, serial beta-HCG titers. We do them weekly until they become negative, and then monthly we will follow up for 12 months. For 1 year, we put the patient on oral contraceptive pills because we don't want to see her getting pregnant. And the reason for that is if the beta-HCG levels start to rise before the 12-month period is over, we don't know if this is a malignant recurrence or is this a normal pregnancy. The longer the period of time since the uterus was emptied and there is no return of the molar pregnancy, the more comfortable we are that it will not come back. Table 6-2 looks at malignant gestational trophoblastic neoplasia. And we have 3 groups, the non-metastatic, the good prognosis, and the poor prognosis. Now, all of these are malignant. The non-metastatic to the uterus only, 100% cure. That is amazing. Good prognosis, you should know this for the exam, pelvis or lung, 95% cure. And both of these two, non-metastatic and good prognosis, are treated with single agent chemotherapy. The most common chemotherapy would be methotrexate. How would you know if it worked? We want to follow up with oral contraceptive pills for 1 year. So we would give the chemotherapy and then we would follow to see the beta-HCGs until they come down, down, down and become negative. So that's going to be weekly, and then 12 months we're going to follow up. On the right-hand column, if it is poor prognosis, metastasis to the brain or liver, that's 65% cure. Now we use multiple agent chemotherapy, and we follow up for 5 years. Now, single agent chemotherapy can be done as outpatient. The likelihood of immunosuppression and low white count is much less than if you gave multiple agent chemotherapy. You can appreciate that the risk of immune suppression would be much higher. the side effects will be much higher, and this is usually done in the hospital. So that's the non-metastatic, the good prognosis, and the poor prognosis malignant gestational trophoblastic neoplasia. The outcomes are really pretty good considering that these are all malignancies. Risk factors. I already talked about this. Increased prevalence geographically in Taiwan and the Philippines. Not entirely clear. Is this a nutritionally based problem? Is it because of the rice? I don't think anybody really knows. Other risk factors are extremes of maternal age. Younger than 20, over 35 years of age. Another one that would be worth remembering for the exam is folate deficiency. Folate deficiency is a risk factor for gestational trophoblastic neoplasia. Clinical findings. I already mentioned this before. The most common symptom is bleeding prior to 16 weeks gestation. So we talked about threatened abortion, the inevitable, the incomplete, and so on. We talked about bleeding, also associated with ectopic pregnancy, but this is associated with molar pregnancy. The other thing the patient may complain of is she says, I passed some grapes through my vagina. Vesicles coming out through the vagina. Other symptoms of a molar pregnancy include hypertension. We talked about that in terms of preeclampsia. Hyperthyroidism because of the TSH qualities of the alpha subunit of the HCG. Hyperemesis gravidarum, which is associated with the very high levels of HCG. And if it is a complete mole, no fetal heart tones can be appreciated. But if you would remember, the most common symptoms would be bleeding early in the pregnancy, passage of grapes, hyperemesis. That's a symptom. That's what the patient complains of. The most common sign, what you would find on physical examination, is a uterine fundus which is larger than dates. If it is a complete mole, absence of fetal heart tones, and bilateral enlargements of the ovary known as theca-lutein cysts. And we talked about that before. These are huge ovaries that just about fill the entire pelvis, and they are a result of the high levels of the hormone. Leave them alone. As the hormones come down, these will involute and return to normal. Clinical findings. I already mentioned this before. The most common symptom is bleeding prior to 16 weeks gestation. Bleeding. So we talked about the threatened abortion, the inevitable, the incomplete, and so on. We talked about bleeding, also associated with ectopic pregnancy, but this is associated with molar pregnancy, bleeding. The other thing the patient may complain of is she says, I passed some grapes through my vagina. Vesicles coming out through the vagina. Other symptoms of a molar pregnancy include hypertension. We talked about that in terms of preeclampsia. Hyperthyroidism because of the TSH qualities of the alpha subunit of the HCG. Hyperemesis gravidarum, which is associated with the very high levels of HCG. And if it is a complete mole, no fetal heart tones can be appreciated. But if you would remember, the most common symptoms would be bleeding early in the pregnancy, passage of grapes, hyperemesis. That's a symptom. That's what the patient complains of. The most common sign, what you would find on physical examination, is a uterine fundus which is larger than dates. If it is a complete mole, absence of fetal heart tones, and bilateral enlargements of the ovary known as theca-lutein cysts. And we talked about that before. These are huge ovaries that just about fill the entire pelvis, and they are a result of the high levels of the hormones. Leave them alone. As the hormones come down, these will involute and return to normal. The diagnosis is an ultrasound diagnosis. The ultrasound confirms homogeneous intrauterine echoes without a gestational sac or fetal parts. Snowstorm. The early ultrasounds didn't have the resolution that we have today. Now, today, we can see the actual cysts in the uterus. But what would be seen previously was just this whiteout, just homogeneous echoes without any sac, without any amniotic fluid, without a placenta. So the diagnosis is going to be made by ultrasound, but whether or not it is malignant or benign awaits the pathologist's report. And so we have to empty the uterus, we have to send the tissue down, and then we will get a histologic assessment which will tell us, is it benign or is it malignant? This ultrasound image shows the uterine cavity with extensive cystic areas. And when you use color Doppler, which looks at the vascular supply, you can see almost complete filling of the uterus with color. On the left is color Doppler. On the right is what we call power Doppler. Power Doppler does not take into consideration the direction of flow. But you can see it is very, very vascular. Table 6-3 looks at our approach to patients with gestational trophoblastic neoplasia. We have made the diagnosis based upon ultrasound. We need to get preoperative assessments. We need to get a beta-HCG titer so we know whether it is coming down or going up. So we need to know where we start from. We need to get a chest x-ray because the most common site of distant metastasis is to the lung. Then we will go to the operating room and do a suction DNC. I want to get a type 1 cross match because she can lose a lot of blood. And we're going to empty the uterus with a suction DNC. We do not do a mini cesarean, a hysterotomy. We do not do an induction using prostaglandins. This is a suction DNC, so we dilate the cervix with dilators, either with a laminaria or with a metal dilators. We put in a suction curette and aspirate all the uterine contents out, and we send it to the pathologist because we want to know, is it benign, is it malignant? And then we will put her on oral contraceptives for 1 year to prevent confusion from recurrent disease versus normal pregnancy. So that's going to be the sequence that we go through. Okay, management of gestational trophoblastic disease. We already talked about this. We want to get a baseline quantitative beta-HCG titer. It's got to be quantitative, and if it's quantitative, it's going to be serum. Because we want to know what the level of our beta-HCG was so we can trace the normal decrease. Chest x-ray to rule out lung metastasis. Suction DNC to evacuate the uterine contents. Okay. Place a patient on effective contraception. The oral contraceptive pill would be a good one. And we want to prevent the confusion between rising beta-HCG titers and recurrent disease which can occur. The treatment is then based on histology and location of metastasis. If it is benign, we do weekly serial beta-HCG titers until negative for 3 weeks. Then monthly titers until negative for 12 months. And we follow up for 1 year. If the beta-HCG titers plateau or rise and normal intrauterine pregnancy is ruled out by vaginal sonogram, that is persistent gestational trophoblastic disease. She needs to undergo a metastatic workup and then be managed with chemotherapy. Non-metastatic or good prognosis metastatic disease, we use single agent. We use either methotrexate or actinomycin D until weekly beta-HCG titers are negative for 3 weeks. And then we do monthly titers until negative for 12 months. So non-metastatic, good prognosis follow-up for 12 months, for 1 year. If it is poor prognosis, metastatic disease, that would be to the liver, to the brain. Then we do multiple agent chemotherapy, methotrexate, actinomycin D, and Cytoxan until weekly beta-HCG titers become negative for 3 weeks. Then we follow up with monthly titers for 2 years, then every 3 months for another 3 years. So the follow-up total is 5 years.